6 times since January?
Since mid-January.
Okay, so in a month.
Yeah.
All right. So onset of some symptoms back and with a diagnosis back in July of 24, so just shy of 2 years ago.
Mm-hmm.
You were told you had atrial fibrillation?
And I think I had it prior to that, I just didn't know I had it.
Yeah, that makes sense. They tried you with metoprolol. It helped some, but it was causing you hair loss.
Yeah.
They switched to diltiazem. That's not been as effective. And
The metoprolol, I don't think I even had an event when I was taking it, but I lost half my hair.
yeah, that's a problem.
And I was very swollen, my ankles on it, and my feet.
The episodes over the past month, 6 episodes, once they start, how long do they last on average?
I've been tracking.
Okay.
So, one was 4 days. So the mid-January was 4 days.
Uh-huh.
Then I had it again for 46 hours on the 26th. Then on the 2nd, I had it for an hour and a half.
Mm-hmm.
Then I had it on the 4th for 9 hours. Then on the 8th, I had it.
You get the idea.
Okay.
You've, when you have these episodes, you can feel your heart racing. You feel
It
palpitation.
doesn't get. I stay in the 90-ish.
Uh-huh. You can feel the irregularity.
Oh yeah.
Okay.
And I feel fatigue. I'm
Lightheaded or short of breath when it's occurring.
Mm-mm.
Are there any triggers? Things you say, boy, if I do that, I know I'm going to get the atrial fibrillation.
So I'm trying to track that too since it's been happening. So I think drinking water, cold water twice might have happened. She's moving, and so I've been very stressed knowing that she's gonna move. And so that I think was a trigger one time. A dream, I woke up in the middle of the night, and it might have been a active dream.
Mm-hmm.
One time I was on social media and I was going crazy.
You stay off social media.
And one time I was just, I think stress maybe.
Okay. Right. It can occur any time of day, wake you from your sleep, midday, or is it more at night, more in the morning?
I would say the one at night was definite, but mainly later in the day.
Okay. No other heart history for you? You've never had a heart attack? When you're active, you have no issues? You have a history of high blood pressure. Do you have diabetes?
No.
Do you smoke?
Nope. Don't drink. They said I had very mild.
They told you you don't need to treat it?
They probably said they were kind of like you could, that kind of on the fence type thing.
Okay.
I've lost 25 pounds.
Nice.
So I'm hoping that will.
It would benefit. Both your sleep apnea will get better with weight loss, and your episodes of atrial fibrillation are likely to reduce with weight loss.
The weight loss I just started in January, and it's keto, and I was wondering, could that be causing this 6 times in a month?
Not that I'm aware of, not that I've heard directly related to a keto diet. And again, weight loss has been clearly shown to reduce the incidence of atrial fibrillation.
Good, I'm gonna keep going.
Do you have any brothers or sisters?
Yes.
How many of each?
2 brothers,
Younger or older?
1 of each. Well, one passed on.
Either with heart issues or atrial fibrillation?
Not that I'm aware of, but my mother did.
What did your mom have?
David.
At what age?
Probably in her 60s.
Okay. So you can blame her.
Yeah.
Let me talk to you about atrial fibrillation. It is the most common heart rhythm disorder. It increases in prevalence as we get older. It's unusual, not unheard of, but unusual for us to see in 20-year-olds. It's much more common in 70 and 80-year-olds. By the time someone reaches 80 years of age, there's a good 20 to 25% chance they'll have atrial fibrillation. It is not a life-threatening condition. It is a nuisance. Some people have terrible symptoms. They know the second it starts, and they can't function until it stops. On the other end of the spectrum, there are people who are in atrial fibrillation and don't know it. They show up for their annual doctor's appointment, they show up for a colonoscopy, and they're told they're in atrial fibrillation. If someone has no symptoms, the primary goals of management are, one, to make sure the heart's not going too fast. Medicines like metoprolol do that. And two, atrial fibrillation accounts for 20% of all strokes, so making sure that stroke risk is addressed, often with anticoagulation, blood thinners. If someone's heart rate is controlled, if they're truly asymptomatic, no symptoms at all, we can leave them in atrial fibrillation. And there are millions of people who are in atrial fibrillation day in and day out, doing all the things they like to do and feel fine. We mostly treat atrial fibrillation, aside from stroke prevention, we mostly treat for symptoms. You have symptoms, so it's worth having that discussion. The options for treating symptoms are to try and suppress it with medication. If the episodes are happening 2-3 times a year, sometimes we could use medicines as needed. If the episodes are more frequent, then we put you on daily medicines. Beta blockers like metoprolol are a typical starting point. If they're tolerated without side effects and they're working, great. If not, we move on to something else. Diltiazem is a calcium channel blocker. It's a related family. It works in a different way and doesn't sound like it's doing as good a job as the metoprolol is doing. There are other drugs that are truly antiarrhythmic drugs that we can use. And then there's a procedure called catheter ablation. Catheter ablation's been around now for over 35 years. It was designed for other rhythms, not for atrial fibrillation, which is a chaotic rhythm, but for more organized rhythms. So the heart is a muscle. The heart is a muscle that has its own electrical system. All other muscles in the body, to contract, get an electrical signal that originates in the brain, goes through the spinal cord. But the heart doesn't need the brain or the spinal cord. It's got 4 chambers. The upper chambers, the atria, are reservoirs for blood. They collect blood from the body. The lower chambers, the ventricles, pump it. So, but over time, the frequency will increase. That's what you're experiencing now. The duration will increase, and then it doesn't go away anymore. It goes from paroxysmal to persistent. The time to treat is now, while it's paroxysmal. Once it becomes persistent, the effectiveness of the treatment goes down. So for catheter ablation, typically for the rhythms that ablation was invented for 30 plus years ago, if you're in a normal rhythm and some other site starts going fast, perfectly regular, we would run catheters up to the heart, trigger that fast rhythm, map out the earliest spot, and ablate it. Or if the short circuit was going in a loop, like that, we would trigger the rhythm, or if you were in the rhythm at the time, put catheters up, map out the loop. I used an example of a pinball before for atrial fibrillation. Imagine this being a toy train going around the track. If we ablate and separate the track, the train can't go around anymore. So these are cures when we do it for those type of rhythms. But with a pinball bouncing around, where do you ablate? And so what we do differently for atrial fibrillation than any other rhythm is we've, over the years, determined what the most common trigger sites are. And the most common trigger sites are the pulmonary veins, the veins that bring blood from the lungs back to the heart. We don't know if they're your triggers, we just know that when atrial fibrillation is intermittent, these are the triggers 70 to 80% of the time. So we run our catheters up, we identify those veins, and we silence them. We get rid of the electrical signals. They can still carry blood, but no more electrical signals. When we're done, that's all we know is the electrical signals are gone. The only way we know if the procedure worked, if you were in that 70 to 80%, is when you come back and say, I'm not having it anymore. Does that make sense so far?
So 80% is the best I could hope for?
80% would be the best you could hope for an ablation. If we wait until the atrial fibrillation is persistent, where it's there all the time, the success rate drops below 60%. So you're in the time frame. It doesn't mean today, tomorrow, next week. But if you're thinking of ablation, you're probably thinking of it in the next few months, not in the next few years. The procedure is an outpatient procedure. It's done under general anesthesia. You come in the day of the procedure. The anesthesiologist gets you to sleep. We access the veins at the top of your leg, the vein on the side of your neck. Occasionally we use both legs, but usually I try and use one leg and the neck so that when you have to lay flat for a few hours afterwards, you can bend one leg and get the pressure off your back. We run the catheters up to your heart. We test your heart's electrical system to look for any of the other rhythms that I just described there. And then we go over, identify those 4 veins, and get rid of the electrical signals, do the ablation. When we're done, we take the catheters out. We hold pressure over the sites. You have to lay flat for about 2 hours. Get up, walk around, and if everything looks good, you go home. We ask you not to do anything strenuous for about a week to 10 days. And after that time, you can get up and do whatever you want. During that week to 10 days, we're not expecting you to sit around or lay in bed. We want you up and about, just doing casual walking. But no exercising, no stretching, no going to the gym or going swimming, just walking. After the 7 to 10 days, whatever you want to do. Not zero. This is the most common rhythm disorder. We do multiple ablations for atrial fibrillation every week. The worst things, heart attack, stroke, death, I have to mention that with any heart procedure. The risk of those are less than 1 in several thousand. The only risk greater than 1% is getting bruising, getting black and blue. It goes away. Injury to a blood vessel requiring surgery, less than 1 in 1,000. Risk of injuring the heart's electrical system requiring a pacemaker, well below 1 in 1,000. Perforation of the heart with blood accumulating in the sac around the heart, something called pericardial tamponade, 1 in 1,000. If it were to occur, we would drain that blood with a needle. If the blood reaccumulated, it could require urgent surgery. I have not had that happen, but it could.
And you've done a lot?
And I've done a lot.
And so that's the worst thing that could happen. What about my other, sometimes my heart races?
Mm-hmm.
Could that be fixed too?
Well, the racing heart could just be the fibrillation. But as I said, when we do the procedure, we will look for any other rhythms, and if we find them, we'll take care of them.
Oh, so you can look for others?
Yeah, if we can and we will.
What about those extra beats or?
The premature beats, those are a little tougher. If your premature beats are coming from those same pulmonary veins that are triggering the atrial fibrillation, they'll go away. If they're coming from elsewhere, they won't.
What would you do if you were me?
At this point, at 66 and with the increasing frequency, I would lean towards the ablation. If you said, boy, it doesn't sound good to me, I don't like procedures, I'd say try medicine. And if the medicine doesn't work, or you don't tolerate it, you can always come back and do the ablation.
So do I get to stop the medicine if I do this surgery?
So as far as you stop the medicine you're on, such as the Eliquis we decide on based on your risk factors for stroke. If your risk factors are low, we would stop it. If your risk factors are high, we'd recommend staying on it. The diltiazem, if the procedure goes well and you're not having any arrhythmias, you could stop the diltiazem ahead of time, or afterwards rather.
What would my risk factors be to stay on that blood thinner?
So for stroke, age over 65 gets you a point. Female has vascular disease you don't have, you've never had a stroke. So you get 2 points. The female gender is a soft one. So, but still, you would have 2 points, you'd be right on that cusp. If you said a stroke would be the worst thing, I want to take all precautions, I'd say stay on the anticoagulant. If you said I hate being on this anticoagulant, I'm afraid of bleeding, blah, 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 I'd say, well, then we think about maybe getting you are you getting a smartwatch, something that would monitor for atrial fibrillation. They're not perfect, so you take some risk.
Oh, I know when I'm in it.
Yeah.
So if I were to not take it, have the surgery, and then warm up, I already know when I'm in it, but
Yeah.
maybe it might be
Although,
different.
after the procedure, some people, we eliminate their symptoms without eliminating the rhythm.
So my watch, if I wanted it every night to see,
Mm-hmm.
then I could pop the pills to start taking it once I knew I went back into AFib.
Potentially, yeah. I mean, that's not standard of care yet. That people are doing those studies right now. But yes, it's something we could consider, and I would lay it out for you once again, like I did now, and tell you what the risks, pros and cons are, and then you make that decision.
Would you continue to take it, or?
I would have a low threshold. Stroke to me would be the worst thing I could imagine.
Yeah.
So
You can't undo it.
can't undo it.
It's just scary to be on, they might bleed out too.
Yeah. Haven't seen a lot of that, and I take care of a lot of people who are on blood thinners. Could you? Yes, but that's rare.
Okay.
But again, we can talk about that afterwards. You don't have to make those decisions now.
And something about the walls, would I be one wall, or somebody was saying there's different, I don't know, I was watching some YouTube.
Veins?
They were saying, they said to ask, how many do you do per year? How do you treat long-standing later stages? Do you target non-pulmonary vein triggers? Do you stop?
Sure, I can answer those for you. So yes, I do a lot, in the hundreds per year. Non-pulmonary vein triggers, we don't usually do the first time around unless there's clearly evidence that you're having arrhythmia from other areas. So first ablation is typically, if we can't identify any specific trigger, we do the pulmonary veins. If someone comes back with recurrences, then we target secondary sites. We don't do them all the first time because we're getting rid of heart muscle. So we don't want to overdo it.
Will I feel that reduction in heart muscle just with my fatigue?
No.
You tell me your success rate. So how often would someone have to do a second?
For atrial fibrillation, 10 to 20% of people end up having a second ablation.
Pretty quick, a year?
Almost never within the first 3 to 4 months. So episodes in the first 2 to 3 months as you're healing up are not unusual. Doesn't mean it didn't work.
Oh.
So
you might have episodes.
just as you're healing.
Okay.
But we're seeing less and less of that.
This is, what source do you use? Radio?
Currently, we're using mostly pulse field,
That was the third one.
but we don't have to decide that ahead of time. We go in usually planning on pulse field, but if we need to do radio frequency in addition, we do. Cryo, we're not using anymore.
Okay. And then so you puncture the neck and you puncture the
Vein
neck?
right here inside of your neck,
And then your
and the
hip?
vein at the top of your leg.
Top of your leg. And if I continue to keep moving weight slowly, I'm doing it slowly.
Yes, I would recommend that no matter what. I tell people that all of these risk factors that you address, they're not like a smorgasbord where you choose the ones you like and you avoid the ones you don't. You need to address every risk factor. So doing the ablation is only part of it. Weight loss is part of it. Treatment of high blood pressure is part of it. You don't have the other ones.
Okay. So maybe after I did this, I'd go on a high blood pressure medication?
Well,
Oh gosh.
nerve,
No. Like when I drink cold water, the vagus nerve.
yeah, the nerve, yeah, vagus nerve. It can be, but based on what you told me, it may be just one cause. Most people can't identify triggers. And everyone looks for them. Everyone wants to know, was it the pizza I had last night? Was it the glass, the double shot of coffee, whatever. Most people can't identify triggers. This is a sporadic rhythm. It comes out of the blue. If every time you had a gulp of water you had AFib, I'd say, yeah, well, that's a cause, or at least a trigger. If every time you had coffee, it would trigger an episode. But yours sound pretty sporadic.
Yeah. And I know a trigger was, I've never been a big drinker, but if I would go out and have a couple glasses of wine, it would almost, that night in my sleep.
Yeah, and again, if it's coming out of your sleep, sometimes that is considered vaguely mediated. So yeah, it could be part of it. Well, let me take a listen to your heart. Alcohol is a trigger. If someone sitting here says, I have a glass of wine a night, do I need to stop? I say no, you don't need to stop.
So coffee
but I say, if every time you have that glass of wine you're having AFib, then stop.
Yeah. And I was.
Same with coffee. If you're having a cup of coffee, I don't think it's gonna be a problem.
Yeah, I have 2 cups and the triggers aren't after the coffee.
Yeah. So again, I don't think that's a problem.
Okay, good. It's like, I can't drink anything now. Please let me keep my coffee.
Well, I'll tell you what, I will send a note over to the scheduler. You can go look at some dates with her. If you decide to choose a date and then change your mind, try and give us a couple of weeks' notice so that we can get someone else in that spot.
Okay.
Okay.
And so 2 weeks recovery, just walking around,
Walking around,
taking it easy.
Yeah.
And you have to go into general, I guess, huh?
Yeah, and our anesthesiologists do a great job. I mean, you come in the morning and you're out of the hospital by early afternoon. So
Do you stop taking the meds before the surgery?
I would have you stop your diltiazem about 3 days ahead of time so that I can look for other rhythms. I don't stop it for the AFib, but for those other palpitations you're feeling, we'll stop it 3 days ahead of time.
Because sometimes my heart will, like the other night, I woke up and it was just, my watch said it was high heart rate, but it wasn't AFib. And I can tell the difference anyway.
Yeah, and so it could be that. I mean, it could be that there's some other rhythm going on.
That'd be nice to get rid of that one too.
We will look.
So 80 is the most I could hope for.
Yeah, which isn't, I mean, it's not 100 or 99, but it's still pretty good.
Yeah.
You know, 4 to 5 chance.
But then it still could come back, because what I was watching on YouTube videos, they said this is, even though you have that surgery, it's still going to progress.
It can. I have people who've gone 20 years without another episode,
Oh,
and others who have, 2, 3 years later have had to come back.
and they could drink wine once in a while?
Yep.
Really?
Yep. All right. Well, let me get the consent form in here so you can at least